settle when you're supine, and then blood settles in the pelvis when you're not supine. Okay. So, in getting back to your point, that's where you want to look for bleeding in the belly.
Okay.
So you can look with an ultrasound, and if you see a separation between the kidney and the liver that looks like fluid, then you know there's blood in the belly, or fluid in the belly. It can also be in the pelvis. Another way you can see it is on a CT scan. Another way you can, but you can't always take a patient to the CT scan because they might be unstable. Another way you can see it is you can actually do a peritoneal lavage. Peritoneal lavage is a procedure where you make a small incision and open the peritoneum, and you put a catheter like a central line in and direct it towards the pelvis, and then you aspirate to see if there's blood in there. You can also infuse a liter of fluid to fill up the belly and then drain it to gravity with that catheter. And then you send that to the lab, and they count like how many RBCs there are and how many white cells there are. But if you get gross blood, if you get fluid or bile, then you know you have a hole somewhere in something. And if you don't grossly see those, then you send it to the lab and they check it. And if they come back and tell you you've got those things there more than you should, then you've got an issue. Okay. It's becoming less and less utilized because of the ultrasound being available in the emergency room, but it is something we still do. So when someone comes in and they're unstable, what are you going to do first? Okay, what's A?
Airway.
What do you do for air?
Make sure they're breathing. You hear lung sound, breathing sounds.
Well, that's breathing. You just have breathing
Airway.
sounds. So what's A?
Make sure the trach is packed.
How do you do that?
Look in, and if you don't see...
Is his trachea patent?
Oh, you check the chest rising?
No, is his trachea patent?
I
It
assume
says
so.
airway open and unoccluded.
I assume so.
Why do you assume so?
Because he is conscious and...
Okay, let's say he was drunk and unconscious, and he wouldn't talk, and he was like,
chest rise?
So if he's able to talk,
Oh.
you can hear his voice,
Yeah.
right? Then you know his airway must be open, because air must go through the airway and past the vocal cords for you to be able to speak.
Right.
So the easiest way to check someone's airway is to ask them a question, or ask them their name. Hey, what's your name? Now they might tell you, it might not be with it, but at least you know their airway's open because they can speak. Now if they're going, that's not a good sign, right? Or if all they're doing is, right, something's wrong.
Yeah.
Now if someone's passed out, they might not be able to answer you, and so you sort of lose that ability to check their airway. Then you have to check other indicators that they're breathing, like chest rise and breathing, and the
Like
air
clear.
passing. But usually if someone's unconscious and they can't talk, they're not going to be able to protect their airway. So you'll have to intubate them to keep their airway open. Then you go to B. What's B?
Breathing.
What does that mean?
Oxygen getting in and out of the lungs.
Okay, so they're breathing. So how do you check that
Pulse that.
before that?
Chest rise.
Because your SATs aren't going to be good if your heart's not beating and there's no circulation. A person could breathe and they're not circulating very well, right? Or their arms and legs are cut off. They were in a bad accident. Happens. Okay? Or they got shot and they've lost the vessels in their arms, right? Shot right through. So you check for breath sounds. Right? Now you might have good pulse ox, even if only one lung is working and one lung's collapsed temporarily. So you listen for breath sounds, you look for chest rise, and you feel for crepitus of the chest. Okay, you check their breathing, and if there's air passing, again, if they can talk to you, that's a good indicator. But you still listen to make sure that both lungs are up. in a trauma, if you don't hear breath sounds on one side, the most likely cause is or hemothorax, so hemothorax, right? It's a collapsed lung, probably traumatically, and the treatment of choice is
Chest tube?
yeah, a chest tube. You want to decompress it and re-expand their lung. Now, if someone has a tension pneumothorax or hemothorax, how would they differ in their presentation? What findings make it tension?
Deviation.
The heart, deviation of the trachea, or the heart.
Okay, so deviation of the trachea, which is hard to tell.
Mm-hmm.
What else?
The heart would be pushed to one side.
Okay, well, you can't see the heart until you get an X-ray, and so far you don't want to get an
Collapsed
X-ray
lung.
when they have tension pneumothorax. Never find tension pneumothorax on imaging,
Okay.
because the patient will be dead by the
Right.
time you get the
Yeah,
answer. So, deviated trachea, okay. You have a collapsed lung, but a collapsed lung could be a pneumo or a tension pneumo. How do you distinguish one from the other?
Is it something to do with like circulatory system?
Okay. So when they're under tension, what does that mean?
You need from
That
us.
means there's high pressure in the chest, which puts pressure externally onto the vascular system, right? What does that do?
Yeah.
It would increase your blood pressure.
Dr. Ben-Zur's office, how
Well,
about you?
it would
Decrease.
decrease
Because you're
diastolic filling
Oh, I
and
think you just
venous
called
return
that.
to the heart, right? Because
You're not.
you're going to overcome the venous
No worries,
pressure,
still
not
called.
really the arterial pressure.
Right.
Okay. So if you decrease venous return to the heart because of this pressure, now what's the pressure in the IVC?
The number?
Yeah,
10.
Okay.
I do not know.
usually less than 15.
Okay.
Okay, so typically around 5.
Okay.
And that's your venous return, right? Your right atrium is usually 3 to 5. Okay, so low pressure systems. If you have a high pressure in the chest, you're not going to be able to overcome that with flow, and your IVC and SVC will collapse. So you're going to see decreased venous return to the heart. Now, what does that clinically present as?
Decreased venous return. Your heart can't pump blood out because it doesn't have blood to pump out.
What happens if you can't pump blood out because you don't have enough blood in the heart?
Cyanosis,
So-
hypertension.
What cardiac functional number would decrease?
The ejection fraction?
Ejection fraction. When your ejection fraction goes down, what changes? What vital sign changes?
Your heart rate would go up?
Your heart rate.
So you try to compensate with the increasing heart rate in order to maintain cardiac output, right? Remember, cardiac output equals heart rate times ejection fraction. So if ejection fraction goes down, your body will try to increase heart rate to keep up. Up to a point, it can do that. When the heart rate reaches a certain point, there isn't enough time for diastolic filling, and you cross over Starling's curve, and you start decreasing cardiac output again. But up to a point, you can increase cardiac output by increasing heart rate. So they'll be tachycardic. So a patient with a tension pneumothorax should be tachycardic. Unless they're on a beta blocker, in which case they cannot compensate. Right? Okay, so the heart rate goes up, and then what happens? Your heart rate's now reached the peak of Starling's curve, and your venous return your ejection fraction is still too low, and your cardiac output is still too low. So what's the next number that changes?
Down, your blood pressure will go up.
Your blood pressure will go down,
Down.
because now your cardiac output is down.
Okay.
Okay, so initially your response to trauma is a catecholamine release, vasoconstriction to try to increase afterload and increase blood pressure. But once you've got a tension pneumo and you've got decreased blood flow into the heart and you're not able to maintain cardiac output because of lowered ejection fraction, when that cardiac output drops, blood pressure will drop no matter what you do. Okay, so cardiac output is going to be down, their blood pressure is going to start going down. So tension pneumothorax, you're gonna have a patient with a pneumothorax, tachycardia, hypotension, and one other sign. Dr. Tumari's office, good afternoon, how can I help you? Hello? Hello?
Increase
Hello? Yes, hello? Your phone sucks, lady. So your oxygenation can go down, but it can also go down with a pneumothorax, so that doesn't necessarily tell you it's tension. So specifically, if pressure is building in the chest and inhibiting blood from returning to the heart, so what would you see? Dr. Tumari's office. Yes, hello. Yes, yes, hi. Yes, yes.
This is when you have like aortic stenosis and stuff.
Miguel Caldera. Yes.
That's the aortic dissection. That's where you have
Still?
the weak pulses in your legs but strong in your arm.
Oh, yeah.
It's an aortic dissection.
What's the one where you there's a specific
Uh-huh.
Yeah, but what would
Yeah, that's fine. Just tell him that he needs to drink a lot and that if he cannot pee by tonight, then he needs to go to the emergency room. If he doesn't pee before 8 p.m. Yeah. Okay? Okay, thank you. Yeah, just make sure, yeah, just give him instructions and make sure he's drinking a lot. Okay, thanks. Bye-bye. Okay, so what else?
Radial pulses are gone?
Well, all your pulses will be weakened because your blood pressure is low. But that's a late finding. You don't want to wait till they code. Physical exam. Visual.
Is blue.
Okay, before he gets blue.
Before he gets blue. Some difficulty breathing, but that's with pneumothorax too.
JVD.
Oh.
So because there's pressure in the chest, the veins can't empty into the chest because this is a low pressure system and the chest becomes a high pressure system. They can't empty. So the veins get distended. So you get JVD, tachycardia, hypotension, and a collapsed lung. That's a tension pneumothorax. If you take out the collapsed lung, JVD, hypotension, tachycardia, those three together give you a different diagnosis.
It's the, do it again,
JVD, tachycardia, hypotension.
Okay.
Now instead of distant lung sounds, you have distant heart sounds. Tamponade. Same thing. High pressure compressing the heart. That's why the clinical picture is the same. The findings are the same. The only difference is the lung's not down. The heart sounds are far away because the heart's surrounded by blood instead of the lung sounds being far away because the lung is collapsed. Make sense? So that one physical exam finding will differentiate from a cardiac tamponade to a tension pneumothorax.
In tension pneumothorax, would you have muffled heart sounds but also muffled lung sounds?
Not really muffled. The heart sounds won't be muffled, but the respiratory will be gone.
Is that real? Oh, you're welcome. Do you have a bowl? I need to return it.
If that would have been real, you would have smelt it before you would have heard it.
The loud ones are not the deadly ones.
What's happening?
What's going on?
What's treatment for cardiac tamponade?
Drain it right away.
Drain the.
Relieve the pressure. Find the cause of the blood. It's usually like with the contusions.
The treatment for cardiac tamponade is pericardiocentesis.
Okay. Oh yeah.
You
That's right.
stick a needle in it and suck the blood out.
Okay.
Make sense?
Yeah.
Alright. And then you gotta figure out why it happens. What else? Hello? Hello? Hey. What's up, man?
It goes around, comes around. Listen to the lake. I just don't want to talking about
Put that thing on hold and stuff, not recording stuff.
Okay.
That's what it is.
very, very helpful.
This is
And then, once you figure out that stuff, what I would do is contact those facilities, first find out if any of them are contracted with Western or not already. If they're students that have gone there in the past that are contracted, it's a lot easier to do. If they're not, then it's a much longer process, because they'll have to get financial agreements with the school and all this stuff. The school doesn't pay them for you, the school doesn't pay for you to rotate anywhere, they just keep your tuition money. But they still have a long contracting process to agree to have you guys be seen. But then call each facility and find out what the requirements are as to taking outside students. If you want to go to USC, you want to go to UCLA, they have applications to fill out, they have certain forms and things that they need from the school and certain things they need from you. And it's a whole process, and they have deadlines. Now, one of the biggest deals is getting your stuff in early, because if, what happened to me is I sent it in and the school didn't finish their part and submit it on time, and then we missed the deadline. And then they just assigned me to Downey Family Medicine. So you need to be very vigilant about following up and following through with those auditions. So make a list, plan ahead. I would get started on it 6 months before your rotations are gonna be, at least. If it's a new place that hasn't been contracted before, you should probably start about a year before. Just get the paperwork and the contracting, because it'll take them a long time to get things done. And anything can be made to be agreed on. It's just a matter of being vigilant enough to make sure that the paperwork goes through. Huh?
Are these for electives or?
Auditions for next year. You don't really get third-year electives, do you?
We
You
have
get a
two.
selective, right?
No, we have two.
This is his.
This is my elective. Or
But you have to pick from sites that
Yeah.
are already
Yeah.
approved.
we can
Right.
get them approved.
No, as in Western, you has to be
Has to
giving
approve.
you options, and then you pick from there.
No.
You can
You
go anywhere
set
for
it
your
up-
electives.
You can set it up however you want.
Really?
and
Like you
just
could
do
go to
this
Toronto
process.
and just
Yeah.
do whatever. Okay.
They've changed things a little.
Yeah, it's changed since I was there. But that's good. So then you guys do the same thing for fourth year. But fourth year, most of your rotations are like that, right?
Yes.
So you gotta just set it up and figure it out. Plan out when you're gonna take your boards. Pick an easier rotation that month, so that you have time
Step
to,
2 you're talking?
yeah, so you have time to freshen up and take time out of the rotation to do it and all that stuff.
Now, they give us a study month, or
You have you can get a study break, a study, I forget what it's
You get a
called.
month
Study
off,
month.
do they also,
rotation first. Well, it's
want
like
us-
your vacation time, right?
don't they also want us to use that for interviews or something?
That's separate.
Separate.
Separate?
Separate.
Yeah, you can't exactly schedule your interviews that well because everybody does them at different times. They're roughly around the same time, like October, November, December. That's the other thing. The main places you want to audition at, you need to do at the beginning of 4th year. Because they will make their selections and offer their interviews towards the beginning. You know, because then interviews happen in like October, November, December, and the match is in February and March. So if by September or October, when they're offering interviews, you haven't auditioned there yet, you're going to miss the boat. So don't audition in December if it's a place you think you're not going to get an interview anyway. Now, if you get an interview, if it's somewhere you think you're going to get an interview anyway, but you want to audition before the match so that they get a chance to see you, it's different. They'll see, you know, you may have already gotten the interview, but you might not get the interview, and then you show up there for a rotation for a month. So, you know, I would pick the places that your higher priority facilities up front, and then the other stuff later. And you should probably do a 3rd year, if you have 2 electives, try to do something in your 3rd year that sort of prepares you for your auditions, so that when you do your sub-Is and your auditions, you don't look like you don't know what you're doing in that field.
So what's something that you recommend, like a field?
So like, I wanted to do general surgery. So I did a 3rd year rotation in general surgery, but I didn't do my 3rd year rotation at a place that was a residency hospital. So then when I went to do my auditions, I was basically coming off of a clinical rotation like this, which was very different. You know, you're not used to getting up at 4 in the morning writing notes, and you haven't been through that practice. So what I did is, the first thing I did is,
Dr. Ben-Zur's office, how can I help you?
July or 4th year, the first rotation in 4th year, I went to a residency hospital to do it. Now that happened to be Arrowhead, because I figured that was probably the place I wasn't going to offend anyone, because I already knew the system. I had been there for other rotations, OB-GYN and peds.
This is your audition.
This was my
Your pre-audition.
This was my audition for general surgery at Arrowhead, but it was also the first one I did. So that then I did auditions at like USC and other places, which were much harder challenges. And so I did one at Arrowhead where I was familiar with everything first. You know, at least I knew the system, I knew how the hospital ran. I hadn't done the surgery department one yet. But ideally I would have done one in like, you know, Riverside County's general surgery that I didn't plan on applying to. You know what I mean? Or like, you know, North Carolina, whatever. Somewhere that it's a general surgery that you don't really care, right? So you can spend a month learning, and then when you go somewhere for your audition, you look good. You know, that's the goal when you're on your audition. Auditions can make it for you, but it can also break it. A lot of people have done audition rotations and then excluded themselves from matching it because they showed up there and just didn't perform. Whether it was their bad attitude, or they were lazy, or they just, you know, whatever it is. So if you're going to do an audition, you need to make sure you work hard, put in double what everybody else is doing. You got to work twice as hard as anyone on that rotation. You got to know patients twice as well. You got to study twice as much. You know, nobody expects you to be at the level of the residents, but you need to work twice as hard as they're working, and every other student is working, so that they know that you have good work ethic. Because what you got to understand is residency to these people that are making decisions, that are choosing you, is like a marriage. Just like you don't marry someone after a first date, right? They want to know you, they want to get to know you, they want to know that you can jive. It's not just about, I want the smartest guy. That's like saying, okay, I just want the hottest girl in the room, I'm going to pick her and get married, right? She might be an ass, but you don't know, right?
And then recheck it
So,
after 30 minutes.
vice versa for guys.
It's okay. No.
But you can't just pick the smartest residents necessarily, but you need to know that they can perform in every function, because you're going to be stuck working with them 80, 90 hours a week for 3, 5, 6 years. So they want to know that you're hardworking, you're not going to give them crap about a bunch of stuff, that you're going to study hard and learn things so that you're teachable, you're hardworking, you're driven, and you get along well with everybody. And one thing that you should all know, because everybody forgets this, when you call the department and talk to their secretary, the secretary of the program director or whoever picks up the phones, or the students that you work, the interns you work with, or those people have a lot of input into your application. So I've had students that looked really good, and then the secretary of the department came up and said, you know what, this guy was an asshole to me on the phone. He kept calling here and yelling at me about his application and this and that, and it's like, I don't like him. And boom, goes, oh, top of the pile? Trash. Done. You just lost the spot. And believe me, I've seen it happen. Or we had, when I was at Arrowhead, we had applicants who we thought, this looks really good. The guy interviewed well, everything. And then one of the interns came up and said, hey, this guy, I've worked with him, and he's horrible. He did this and he did that, and he's not going to fit in here. Okay, he's not going to fit in. He's not going to fit in. So be nice to everybody, bestie. But what I was saying is, what they want to know is, because it's like a marriage. It's not just that you're smart. They want to know that you know what you don't know. They want to know that you're teachable, that you can learn things. If you go there and argue back with them about everything, that's not smart. That's just cocky, and you're going to be difficult to teach. So that's not what they want. They want someone that's teachable and will take criticism well and make it constructive. They want to know that you're hardworking, that you're committed, that you're not going to make excuses, that you're not always trying to come in late and leave early and, whatever. So when you're on your rotations, it's got to be like, this is it, I don't have a life, and this is all I'm going to do this month. If they want me to come in at 3 a.m., I'll do it. If they want me to work 7 days a week, I'll do it. They know it's unreasonable, but they ask things anyway. And when they see somebody that just, this guy was here for months, he never heard shit, he never complained about anything, he did it, whatever. Like, let's take that guy. Because every resident knows in that hospital, and every attorney knows in that hospital that, okay, this guy's in our residency program. 2 years from now, if resident X ends up having a baby and needs to leave in the middle of the day, or resident Y gets sick, or something happens, these guys will step up to the plate, and they're not going to just sit around and mock. That's all they really want. They want people that are going to work hard, do the right things, and be safe. Right.
So then when you say you call when you call the sites to make sure everything's going well, you just...
So that's sort of that story. Makes sense? Mm-hmm. So be on top of things, follow through, make sure things are getting done. Whatever step along the way it needs to happen, then just make it happen.
Did you ever... There was another... He's now his second year in residency, and he said he double booked rotations. Western says not to do it, but
I don't know if Western will let you do it.
Well, he did it himself. He would... It's Casey.
He did two?
No. He would double book and then go through the process, and if something,
Just cancel
if
it.
something.
Oh,
blew
you'd
up
work
in his
on two
tank,
rotations
yeah.
at the same time.
Yes.
Yeah, they tell you not to do that.
Mhm.
It's not a bad idea. Get two things started at the same time.
Mhm.
I would caution you that you might confuse the rotations office and they may be more likely to drop the ball on something.
Okay.
As long as you're on top of it and following through very aggressively so that they don't drop the ball or get confused. You know, like if you're trying to go to UCLA and USC at the same time and USC calls and says, hey, you know, we need the paperwork for this rotation, and someone over there goes, oh no, we have it down as going to UCLA that month. They're just gonna cancel everything out. So don't do it with like the most important ones, but yeah, it's good to have a backup plan.
Okay.
Now, sometimes the backup plan is not another audition, but it's something that you know you can get anytime. Like, I did this rotation as a backup once. I had already been here, and then I had another rotation that fell through at the last minute, like literally 2 days before. I'm like, I don't know who's gonna just take me on a moment's notice. I called Dr. Ben-Zur. He's like, yeah, sure, come on over. You know. And so I did this rotation again, and I ended up doing like a bunch of research that month and doing other stuff while I was here. So there are certain places that you know will work with you and certain people that won't. And like you can't call Arrowhead and be like, oh, can I just come in last minute? You know what I mean? They've got such a structure. There's so many students there that they can't do that. They can't accommodate people like that. It just throws their system off. And you'll see when you go there, there's so many students, it's like, it gets obnoxious sometimes. So there are places though that can accommodate somebody, you know, at any last minute. So have those options open. If you want to work on more than one audition at the same time, just be careful that you don't get
Caught.
well, not so much get caught, but don't get screwed, you know.
To double book as in like you have it
I
planned.
have to ask him. He's at
And then
Ventura.
you
so-
end up telling one of the schools like, oh, I'm
Yeah, you
doing
end up
it.
canceling
Yeah.
on one of the places at the last minute
So
and
you
saying,
kind of
I got my
have
other
the ball.
rotation and I'm dropping this one. But that can backfire too.
Yeah.
Yeah.
You know, if you drop it last minute, then they may remember you.
Right.
And if they remember you when your application comes up for residency, if you still plan on going there, they may look at it and be like, this guy just dropped our like rotation at the last minute. He never even showed up, and you know, we don't like him. I mean, you never know. It just depends on who's the one that's dealing with your rotation, and if they're involved in the other process at all or not, or if they happen to bring it up to somebody. But it does happen. Like we had a student that didn't show up for a rotation. Now maybe they had canceled, nobody knew, but they were on a list of people that were expected to show up one day, and then all these students showed up and this guy didn't show up. For a week went by and nobody ever saw him, and we're like, oh, you must not be coming, right? Later when that name shows up in a list, people just go, oh, he's, you know. Now it could be that it's not your fault. It could be that the school just dropped the ball and forgot to tell the facility or whatever it is. But when it happens at the last minute, if it looks bad, then it might make a bad impression. So be careful which facilities you do that to. You know. What are you guys going into? I think I asked before.
I like radiology a lot, but I'm hesitant.
Have you done a radiology rotation?
It's my first rotation.
Okay.
Yeah.
I don't know yet. I'm between surgery and peds.
Yeah.
It's kind of a weird thing to be between.
Yeah,
But
very different worlds.
I really like kids, but I don't know if I could deal with them every single day.
It's
And
not
I
the kids that are hard to deal with, it's the parents.
Yeah.
The kids are great.
I think it was the parents that, because I just came off peds and I loved my rotation, but I don't know. But I've always thought I wanted to do surgery.
Pete surgery.
Nikki
The NICU was awesome. I did a week at NICU.
You could do ped surge, you can do peds cardiology,
NICU was
You can-
so cool.
there's a lot of that stuff, but yeah, that's a very different,
That
two
is.
very dichotomous worlds, so
But
you
it's
gotta
like the
figure it
same
out
patient.
quick.
Yeah, well, that's the hard part is
Yeah.
neither of them would go together as far as auditions.
No, I mean, you're looking at
Yeah.
completely different sides of the field.
Yeah. I know.
I think you like both of them because you're not talking.
Yeah.
Yeah, essentially, you don't want your patient to be able to communicate.
The interaction is
Yeah.
much more minimal.
Yeah.
I don't understand what you're saying.
Pathology.
I put you to sleep.
Pathology.
I want to.
The common ground.
You want to actually see
Common
someone.
ground. Patients, you can't kill anyone,
Wow. Oh, that's very true.
they're already dead. If you're doing autopsies, they're already dead. You get to do surgery without any more. Like I went to an autopsy and I'm like, dude, don't, like, you just ripped the freaking diaphragm. He goes, so? Like, oh yeah, he's dead. Like, I'm so meticulous. The guy just took like giant scissors and sliced the guy in half. Holy shit, you can't do that.
That's very
If there's blood
rough.
vessels there.
So
So,
They're very rough.
it's a very, yeah, but you gotta pick.
I know.
Need you for 30 seconds.
Where were we?
Just talking about what you're gonna
Double
Even for surgery
Okay.
and audition,
Yeah, so you gotta figure that out and then set up your auditions, cause
completely opposite.
they don't go very well together. What are you going to do?
I was thinking about doing IM or gem surge. I'm not sure because I haven't really experienced it yet, so that's why.
Do you like chronic diseases,
No.
like diabetes and hypertension?
I think so. Yeah.
Then do that.
Okay.
I mean, that's the basic difference. There's a lot of medicine in surgery. There's no surgery in medicine. But in IM, you're managing those chronic diseases all the time.
Yeah.
Whereas in surgery, your goal is sort of the things that can be fixed, as opposed to the chronic issues that can't. You know what I mean? You deal with the complications of the chronic issues, and you deal with them as comorbidities, but that's not the area that you put your efforts into fixing. You know, if you know what I mean.
That's like what I think I like the two things that I like.
Yeah. Sick.
There's no peds and surgery.
No, as in there's no sick.
Oh yeah, there's
Yeah.
sick people.
There's an end to the things.
Yeah. Alright, so let's talk a little bit about blood pressure stuff, hypertension. What do you guys know about hypertension?
Number one killer.
So cardiovascular
Silent
disease is the
killer.
number one killer, right?
Silent killer.
Silent killer.
You might want to unpause and pause it, like make it
Why?
more, so it's like
Oh.
hypertension.
Oh.
So we talked about